So in the past, especially with photodynamic therapy and laser, lesion composition mattered. You know, classic, minimally classic, 100% occult. Is that as much of an issue now, or you know, I know your group, Jason, has really been at the forefront of talking about type CNV types. You know, which one do you think is more important in the era of anti-VEGF?
I think that when we started with anti-VEGF therapy, I think we kind of tossed out the idea of lesion type as being important, and I think we just merged in the idea of if they're leaking, we will treat them with anti-VEGF therapy. I think as we've gained experience in treating patients, we're starting to see that in fact there are subgroups of patients that may do better or do worse with treatment. Patients with RAP lesions, which used to be the bane of our existence, where they were the most difficult to treat with the other therapies that we had, now have become some of the most responsive, albeit may need more treatment, but they've become very responsive. On the other hand, if you see a patient with an occult lesion with features that suggest maybe there's a polypoidal feature to it, even on fluorescein, you start to worry right away that this may be someone that may not be as responsive. It doesn't necessarily change what I do from day one, but it certainly changes what I might say to the patient and what my expectations are going forward, and alert me to pay more attention to that. So I think that lesion type and classification, even with anti-VEGF therapies, it may be important, and certainly as we start to move into a new area of adjuvant therapies, may become very critical to custom tailor your therapy. So I think as retina specialists, we shouldn't throw out our knowledge base on lesion types and characteristics and try to maintain that as best we can.
Mm-hmm.